Hi everyone, my name is Vincenzo Berghella. Once again, welcome to another AJOG MFM live update for the month of February. Again, I'm here with my co-host and the wind behind this sail, Dr. Mhatre. Mo, how are you?
Hi, everyone. Welcome. For those of you who have been in the blizzard, I hope you guys did okay. For those of you in warmer weather, we are all incredibly jealous. So thanks for joining today. I'm Mo Mhatre. I'm a maternal fetal medicine specialist and the director of the MFM Fellowship at Tufts. For those of you who are unfamiliar with our format, we go through some of the really fantastic work that's been published in this last month's issue. This month, we're going to do February, and we highlight 4 articles that we want to share with you. These are listed here. These are articles that we feel have a robust study design or try to answer some important questions for either labor management or management of our pregnant patients in the office. And we try to pick studies that would be applicable not only to just our MFM colleagues, but also to other prenatal care providers like our OB/GYN generalist colleagues, midwives, nurse practitioners, PAs, family medicine docs. We're going to do high-level highlights today using visual abstracts. I've created the first 3, and the last article is created by the authors. But please feel free to read the articles in full on the AJOG MFM website. And with that, we're going to get started. Vince, why don't you kick us off for the first one?
Thanks, Mo. So, Dr. Dutra published this article. She's boarded actually in both OB/GYN and infectious disease, was one of the few in the countries. And the title, I think, says it all: hepatitis C treatment during pregnancy, time for a practice change. It's well known, as you can see in terms of the situation, that direct-acting antivirals have great virologic response, will really cure outside of pregnancy. And while our AJOG MFM still say not to treat hepatitis C in pregnancy, it's actually a perfect time to treat in pregnancy. And there is more and more evidence that Dr. Dutra nicely summarized in this article that the usual, standard sofosbuvir containing regimens have safety data and efficacy data in pregnancy and show comparable outcomes to non-pregnant adults, meaning, cure. The data so far don't show any congenital anomalies, however, neonatal or maternal outcomes. There is a trial going on, but I also want to announce that actually here at Jefferson, we have started treating hepatitis C in pregnancy thanks to Dr. Dutra protocol. One patient has already delivered with great outcomes so far in terms of viral load, resolution, etc. Another one is almost finished treatment. We usually treat them at the end of the 2nd, early 3rd trimester in time, to get to a full treatment in pregnancy. And we have a couple more that are starting treatment. I think this is a revolution. I've been wanting to see this for a long time. These patients often have difficult social histories of use, etc. And pregnancy is a perfect time when they're actually getting care, they have insurance, etc. To treat. And I am so happy to share this report from Dr. Dutra and the fact that not only us, but I'm sure many places are starting to treat.
Yeah, this is really a game changer, and I look forward to seeing what those final results are from the trial. But certainly it sounds like what is available so far can help us use some shared decision-making for the patients we serve. So really, really interesting, and I'm glad to see her work here. The next paper I want to present is Advanced Prenatal Counseling and Support for Parents Carrying a Fetus with Congenital Anomaly. This is a scoping review that was done. And really trying to understand, when we walk into a patient's room and give them a diagnosis and then have to lead them through the next steps, what is the best practices for that? And they reviewed over several articles. They narrowed it down to 43 studies that specifically focused on 2 major aspects: the process of actually referring a patient over either to MFM or fetal care center, the counseling involved and that process of counseling, and then how the information was delivered and the amount of content or kind of the formats of the content. What they found was there are a few key steps in between the process and the information that's given. One is a timely and prompt referral. Having that delay creates a lot of anxiety in parents, understandably. Two is having a multidisciplinary team to really handle not only the medical information, but also provide a lot of psychosocial support, because this is such a impactful, transformative, and stressful time for parents. And with that, also a dedicated case manager to help navigate all of the whole healthcare system, which I think all of us know as medical providers is quite complex and can be overwhelming for those who are not in healthcare themselves. And then importantly, to have uniform, consistent messaging across different specialists, because that can create more confusion. Be compassionate, obviously, and non-directive to really integrate the patient's preferences and values. Trying to be comprehensive, but also neutral in light of that. And also trying to give information in different formats and in stages, just because it can be overwhelming to hear all of that all at once and then try to make a decision immediately. And obviously, supporting patients' right to termination and helping them with access to that as needed, depending on where you live. So in summary, having this kind of holistic approach, compassionate, patient-centered approach is really what's strongly preferred by parents. And I think being mindful of that, it can help us when, we have to walk in that door and share some news. I think it's really important to keep these things in mind. So having this light I think it's really nice to see this framed in a really structured way by these authors.
We don't talk about this enough. This is so important, Mo. I'm glad you highlighted this article. So important. Next, it's an article from Keely Robinson, Dr. Bolligan, and colleagues. There's a cervical dilatation staging that was published by Dr. Ruman a couple years back, also in the Pink Journal. And basically, they used this IC-Clear database to see if this staging system, looking at both the length of the cervix on ultrasound, but also the exam, by manual exam, would correlate to the incidence of early preterm birth. The criteria go from 1 to 5, with 5 being so dilated that you cannot put a cerclage. 1 would be kind of a long cervix closed and on exam and long on ultrasound. And basically they looked in particular at when the cervix is dilated. So let's say you're looking at exam-gated cerclage maybe before 24 weeks and she's dilated. Are the membranes that are the internal, not in the external os 4A, at the external os 4B, and past the external os 4C when it's even more difficult, if not unfeasible, to place a cerclage, for example. And they saw that actually the staging was good because progression meant higher risk of preterm birth, 25.9% for 4A, 44 for 4B, and 75% for 4C. And I actually use this now for counseling. Mm-hmm. So if somebody presents, for example, at 22 weeks and she's 3 centimeters dilated with membranes behind the cervical os, I tell her that even with a cerclage, she has a 75% chance of delivering before 28 weeks. And in Pennsylvania, termination would still be available at 22 weeks. It's not that they have to terminate, but it's good that they know that when they're so dilated with membranes past the os, no matter what we do, the prognosis is not the greatest. Well, it's much better, as you can see, if the membranes are at external os or above. So I thought that this was, helpful clinically.
Yeah, definitely helpful to add that stat, I think, in counseling. It's just more information so they can make the right choice, or at least be informed when they put the cerclage in. And our final paper today is a randomized controlled trial on real-time continuous glucose monitoring for self-management of gestational diabetes. And this was from the group at University of Washington. And so, there's been a lot of data starting to come out with CGM use in gestational diabetes, and, it's approved by the FDA. But it seems to be that the data is a little bit mixed. Like some are finding maybe some help. Other studies are not finding that it's changing much of the outcomes. And so this group wanted to do an RCT to contribute to the literature and try to get some more data to help us understand really the utility of CGM. And so they randomized patients who were diagnosed with gestational diabetes, who were not on medication, to either having a real-time CGM that the patients were not masked to, so they could see all of their results, versus patients who had a CGM, but they couldn't see the results. They were blinded to them, but they just checked finger sticks routinely. And then they wanted to see if that changed the rate of their time in range in their CGM, if it changed how many of them actually needed to be started on insulin, or if the dose of insulin needed to be adjusted, or maybe not at all. And so they had 105 patients, about 53 in the real-time CGM group, 52 had the blinded CGM and finger stick group. Interestingly, over half of the patients who were in the finger stick group withdrew from the study because they really, really wanted to have CGM and having those results, and they just they couldn't continue the study because they really wanted those results. They did a lot of work on looking at the time and range, and there wasn't any different. They were pretty similar. There wasn't really much difference in that. Interestingly, I think because of all that extra data, it was unclear if there was some bias, but more people who were on the real-time CGM group initiated insulin, and the outcomes were the same. They did a lot of patient satisfaction evaluation, and they found very high satisfaction with the real-time CGM. Patients did find that it gave them a lot of education about how what they're eating is really affecting their sugars. They found it easy to use. So it clearly is a popular thing amongst patients, but doesn't seem to really change the difference of their glucose levels. And if anything, may increase their chance of needing insulin, but not change their outcomes. So I think it's interesting data. Certainly is something that I think our patients want, so they don't have to check their finger sticks. It's easier to like set it and forget it. But hard to say right now, like what that means for how we're going to manage patients, and how we're going to make a difference with this otherwise.
Great. That's our wrap. Very interesting study. I think, clearly cutting edge and, practice changing like we aim to be at AJOG MFM, the Pink Journal. Thanks, Mo. And I hope everybody can stay, warm and avoid any more snow. And we'll be back soon for our March issue.
Yeah. Thanks, everyone. We'll see you next month. Take care. Bye-bye.